Good evening, all the aspirants present here.
Good evening.
Good evening. We are going to start our session. So, more students will be joining us soon. So, today's topic is metabolic diseases, and the speaker that we have here is Dr. Sujay Samanta, who is Associate Staff Associate in Critical Care Medicine and Division in Cleveland Clinic, Abu Dhabi, UAE. Hello, sir.
Hi, good evening to all of you.
Good evening, sir. So you may start the session. More students will be joining us soon, and it is going to be an interactive session. Thank you.
So we are discussing about the maple syrup urine disease. So next slide, go to the next slide. We already discussed this thing. Yeah, in this pathway, we can see that there is three branch chain amino acid which are being initially the branch chain amino transferase. The first enzyme is amino transferase, which is basically producing the keto as all these this branch chain initial acid alpha keto amino acid is formed initial metabolites. Then the next is the dehydrogenase, which is actually after that pathway it will come the acetyl CoA or succinyl CoA, the final metabolites for this. The either it will go into Krebs cycle or the other cycles. So in this is the enzyme deficient dehydrogenase complex which cause this maple syrup urine disease. Next slide, please. Okay, so diagnosis is basically the elevated level of branch chain amino acid and their immediate metabolites, and also the lactate pyruvate will be as a bypass. It will be elevated, and this will be detected, as I said, by different chromatography techniques or by the biochemical test. And some we can even detect the enzyme in the if the family history is there in the prenatal as in the amino site or chorionovilla cells as well. Even after the newborn, we can screen this with this some mass spectrometry technique. The enzyme can be assessed and we can detect the classic that maple syrup urine disease as well. Next slide. So management, nothing much is there. Basically, dietary restriction of the branch and amino acid has to be done, and there are several formula feed are there. So we that has to be given, and we can't eat a medical food. So it's a nutritional medical therapy, and it has to be maintained throughout the life because this is the irreversible enzyme. There is nothing we can change the enzyme as a supplement to metabolize this amino acid. And sometimes the thiamine, some response are there, so thiamine trial can be given. And in some of the patients of maple syrup urine disease, in addition to the dietary therapy, and but this is if the thiamine is responsive, then it is very good. So we can continue the thiamine therapy along with the dietary therapy these cases. And whenever there will be some metabolic decompensation or anything, this is very serious issue. So and this has to be to be dealt with very treated aggressively. And so we have to be careful not giving those patients with any sort of branch and amino acid containing food, basically. Next slide, please. So next topic is phenylketonuria. So this is basically aromatic amino acid phenylalanine. They are this metabolism problem. Here also the enzyme deficiency is phenylalanine hydroxylase. So this hydroxylase enzyme is deficient. So if we don't treat this, what will happen? There will be again the metabolites will be accumulated in the body, and it will have impact in different when it will be deposition or it will be in the different organ. It will have a deposition, or the effect itself will have some mostly neurological symptoms, and also the skin problem as well. So the major cases of phenylketonuria is caused by this hydroxylase enzyme deficiency, and so it will result in the blood and the urine concentration of phenylalanine and its metabolites like phenylacetate, phenylactate. So phenylalanine itself, also the immediate metabolites like the phenyl acetate or the phenyl lactate will be increased in the blood and urine. And but tyrosine is the next step, next metabolites from the phenylalanine, so it will be normal, and most of the cases it will be normal. In some of the cases there will be other, like there is an enzyme which is like in 2% of cases, this hyper phenylalaninemia defect due to the tetrahydropitin hydrogen metabolism. This is actually cofactor in the hydroxylation pathway. So if the cofactor, either the enzyme deficiency or the cofactor deficiency, which will have the defect in the metabolism of phenylalanine, and ultimately the phenylalanine and its metabolites will be increased, and those will be secreted in the urine, and also it will be elevated level in the plasma. So in there is enzyme deficiency, it's up to the different variable degree are there. Like if the complete deficiency are there, in such cases the phenylalanine concentration will be very high in the serum. It will be very high, like greater than 1200 micromillimole per liter, and urine also will be very elevated. But if the some enzyme activity is there, so depend on that, there will be we can and the phenylalanine concentration will be different variable amount. We can categorize it mild phenylketonuria or moderate ketonuria, like that. Next slide, please. So here also the main management is the dietary restriction of the phenylalanine, because we don't have the enzyme to metabolize this amino acid. So we should restrict the intake of this phenylalanine. And there are some enzymes are there, like this uh, pegvaliase, that is approved for the adult patient with PKU. But the mainstay of therapy is the dietary therapy, dietary restriction. Basically, it is the initial therapy we should always be implemented immediately. And sometime, as I said, that there is a fact, the bihapterin, this cofactor deficiency also can have some effect in the metabolism of the phenylalanine. So that's also one of the reasons, but very minor cases. And so the main therapy is the dietary restriction. And some pharmacotherapy is that if the patient has a mild to moderate phenylketonuria, in that cases, like synthetic, that cofactor BH4 is available, which is called sapropotin. So that can also be in as an adjunct to the dietary therapy, can be added to mild to moderate PKU cases. So that's the point. And another thing is, for the patient with this bihaptotin 4 cofactor deficiency, we have deficient neurotransmitter precursor like L-dopa, carbidopa, and serotonin are also provided. These are to improve the neurological symptoms. Actually, as I said, it's the phenylalanine, its metabolites have a lot of neurological symptoms. So these are these precursors will have the neurological symptoms will be less. And the monitoring of the blood concentration, as I said, phenylalanine and tyrosine should be monitored frequently, and especially during the infancy. And out that once we ensure the dietary management, most of the things will be the symptoms will be resolved of the this phenylketonuria, except if it is the cognitive impairment already happened, then that usually doesn't reverse. Next slide. Next topic is alkaptonuria. So it is an autosomal recessive disorder, and the basic deficiency is the homogenesic acid, that dioxygenase enzymes is the defective enzyme here, and which is basically the tyrosine metabolism's pathway. It's a defect. So this enzymes, this homogenetic acid dioxygenase, basically ultimately will be impact on that homogenetic acid will not be metabolized. So it will be again will be accumulated in the body, and then it will be deposited in the different connective tissues. So when this homogentic acid polymerizes, it's kind of a pigment form as a pigment when the more molecules join together and polymerizes. So it will mainly deposition through this connective tissue and in the cartilages, in the joints, in the and even in the sometime in the eyes, in the sclera itself. So this pigment, when it involves the large joint like the lumbosacral joints and even the disc itself, so it will symptom as a osteoarthritis or arthritis kind of things, and sometime it will be like ankylosis, joint stiffness will happen. Inflammatory as well as non-inflammatory ankylosis can also happen. And now how will you look like if it is coming in the urine? It's normally freshly it will, it's a normal urine. But when you kept it for some time, so the urine become dark brown or the black color. So because this homogentic acid, it's also oxidized and make it it's a black color. So it's also called, it's a black urine disease. So level of this homogentic acid in the blood and the urine and the tissue samples are the basically diagnosis. So diagnosis is a quantitative measurements we can do in the urine, and also we can do the gene involved in the HGD gene. We can do the gene detection as well. In this case, the tyrosine level are usually normal. So there is no approved treatment of this alkaptonuria, although there is a enzyme called basically the, some therapy is there like nitisinone. There is an agent which inhibit the second enzyme of tyrosine catabolic pathway, which is the immediate the prior metabolic pathway. If we that basically uh, decrease the production of homogentic acid itself. So this way that involved as a treatment for alkaptonuria, and which causes basically the decreased urinary and blood homogentic acid level. So this agent can be used, but I think this is still either like in the studies, not even in the clinical effective, I mean no clinical effective study still yet for the clinical use. Next slide please. So we can easily see here in this is the phenylalanine from their tyrosine form, and here some hydroxyphenyl pyruvic acid from tyrosine to 4-hydroxyphenyl pyruvic acid is there. Here is the medicine which is the investigational therapy here. If it block the formation of homogentic acid, so this way there will be less homogentic acid which will not be basically deposited in the body, and the I mean the high level of blood and the other connective tissue. So this is the way this drug can affect. And alkaptonuria happen when this homogentic acid dioxygenase enzymes which is deficient here, which will lead to the homogentic acid level accumulation in the body, which is the basic mechanism of alkaptonuria. Next. So here, this slide basically just kept different organic aciduria and maple syrup urine and even the other metabolic inborn errors, with just to see how is the clinical biochemical findings to compare between them. So here we can see basically just to show that hyperammonemia will be happen. If the hyperammonemia pattern will come, this will mostly fit with the urea cycle defect, because ammonia is metabolized in the liver to make urea, and there will be if the urea cycle different enzymes are deficient, the hyperammonia picture will come. So this you have to identify the pattern of illness and the pattern of biochemical finding which will fit to the disease. So hyperammonemia will be in the urea cycle defect. And if we see the metabolic acidosis, it is basically all the organic acidemias it will come. And if we see the respiratory alkalosis, again it is in the urea cycle disorders. And hypoglycemia will be more of the carbohydrate metabolism problem or the fatty oxidation disorders. So these two are the basically patient hypoglycemic episodes will come. So these things are more there. And lactic acidosis will come either in the carbohydrate metabolism and even in the with the this amino acid problem, and including the mitochondrial disorder. So major lactic acidosis is higher is in the mitochondrial disease and also the carbohydrate metabolism, and in some cases of amino acid metabolism, because the acetyl CoA formation will not be there, so it will be the alternative pathway will be there, so lactic acidosis will be increased. So pattern detection is important here. Next slide, please. So in this slide, basically, I wanted to show that some clues from the urine, how to identify the inbound error of metabolism. So as just we saw in the before slide that in homogenic in alkaptonuria, the urine will be black color. So in case of tryptophan metabolism problems, it will be blue color. If it is hemorrhagic something, it will come with a pink color. And in porphyria, we'll discuss in the next class. In the porphyria, it's kind of wine color urine. It's come. So there are other urine order also, and like maple syrup urine, this look like a maple syrup. And some tyrosinemia, it is cabbage like urine order. And in case of phenylketonuria, it is mousy order. So this order is also just to identify the diseases and the patterns very quickly, because these are the classical pictures, actually clinical pictures. So if you remember these things, so it will be easy to differentiate between the disease, even if you forget the enzymes. Next slide, please.
So may I show the next slide?
Yes, please. Okay, this picture basically, this is the urea cycle pathway. So we see that here is the ammonia is there, and ammonia with the bicarbonate have basically formed this. We can see that it formed this citrulline, and then with the ornithine it will come citrulline to arginosuccinate, and then from there argine, and then finally the urea is formed. So here there are several defect, the enzymes deficiency will be there, and the urea cycle defect will be there. In this, basically the ammonia will be high, and the immediate when once the enzyme will be deficient, the immediate precursor the metabolite will be high. Please, next slide, please. So here we can see there are some cases of ammonia, like in arginemia, the elevated plasma arginine will be, as I said, the enzyme will be deficient, so immediate precursor. So you need to know some of this urea cycle disorder, where the which product which the metabolite will be high, and that's depend on the which enzyme is deficient. So based on that, basically the metabolite will be high in the plasma, and that will lead to this, basically how will you detect the defect of this disease, or you can even detect the enzyme deficiency itself as well, through the metabolites or through the enzyme. So these are these some pattern of abnormalities I am just sharing. That's what will you get in these cases. So next slide, please. Now next topic is cystinosis. So cystinosis is basically a lysosomal disease. It's characterized by intracellular accumulation of cysteine. So cysteine is accumulated in the cell itself and in the different organ and tissues, and which basically cause the organ dysfunction. What is cystinuria? Cystinuria is a different disorder from the cystinosis, where basically the defect is nothing in the metabolism or cellular accumulation. It's basically excretion problem. So impaired tubular reabsorption of filtered cystine, which is already in the urine. It's not impaired reabsorption, so it will be finally excreted to the urine, and so there will be higher concentration of cystine in the urine, and which cause cystine kidney stone. So that's the pathogenesis in cystinuria. So cystinosis is a basically intracellular accumulation of cystine. So that's the autosomal recessive disorder, and it's a genetic cystine gene which encodes cystinosin, and this basically a transporter which is responsible to export the cystine from the lysosome. So if it is not able to export it, so ultimately it will be accumulated inside the cell. So diagnosis of cystinosis is confirmed by either elevated intraleukocyte cystine content. So cystine content will be high basically, and demonstration of cystine corneal crystals. So cystine will be once the cell it is deposited. So in some of the cells you can detect directly, like in the cornea, it's by slit lamp examinations, like the way we do in KF ring in copper deposition. And the detection of, either we can detect the gene also, the CTNS gene variant also we can detect the gene. So management is basically symptomatic. So it's the as it is mostly affect the kidney, so we need to balance the fluid balance and the electrolyte corrections. And if the patient is vitamin D deficient, we have to correct that. And uh, and also whatever the loss is there, the vitamins and the electrolytes, we have to correct that. There is one agent like cysteamine. So we this cysteamine is we recommend treating all patients of cysteamine as soon as the diagnosis of cystinosis. So this cysteamine is basically decrease and delays the risk of kidney disease. So like kidney, basically it will be cystine stone, and finally it's obstructive uropathy, and the kidney tissue will be damaged based on this how much this obstructive uropathy the impacted the kidney. And so this is the major mechanism, and ocular administration of this cysteamine also reduces the ocular discomfort and photophobia. And although the cysteamine treatment does not correct the proximal tubular dysfunction, but has no effect on fluid and electrolyte losses. So it's the defect is it doesn't correct, but it's correct the symptomatic progression of the disease. And even when the end stage kidney disease and happen, then the treatment obviously will be the kidney, because it damages the kidney to that extent the patient need when it is end stage, will need the kidney transplantation. Next slide. The next topic is cystinuria. Cystinuria is a different disorder from the cystinosis. As I told, cystinuria is the problem of excretion, the reabsorption of cystine from the tubule. So the more cystine in the urine, and it will form the kidney stone, and which is the major mechanism. So it causes basically nephrolithiasis. So it started from the infancy and late childhood, and even in the adulthood we can see cystine stone is also normally it is it's radiolucent, but it can be detected in the CT as well. And normally other all kidney stones are basically radio opaque. They are easily detected in the even abdominal x-ray, and but CT is obviously better for smaller stones. A larger stone even can be seen in the x-rays, but cystine stone is basically it can be seen in ultrasound, radiolucent, so it can be seen in ultrasound and CT, as both of the you can choose. So diagnosis basically the main usually we suspect when the patient have kidney stone disease, and and having recurrent kidney stone is coming from the childhood, and a family history of kidney stones are there, so we do a stone analysis of the urine, and when it comes the cystine related stone, then we suspect the cystinuria actually. So treatment is basically to maintain the cystine concentration in the urine in a low concentration, so that below the solubility level, so that it doesn't saturate to form stone. So and so that's the basically goal. And so other important thing is the increased fluid intake, so that the urine concentration of the cystine will not be much higher. If it is more concentrated, the urine stone formation will be more. So as for all stones, we advise for more water intake. That's hold for here also true. And there are some other agents which can be used also as the additional therapy, like the thiopronine and the penicillamine. All these things can also be used, but the main important thing is to, when we are giving therapy, we should always monitor biochemically and radiologically about the cystines, the how is the stone in improvement or not. So all these things, so existing stone size, and any new stone formation happening or not, so all these things has to be monitored. Next topic is homocystinuria. So homocystinuria, basically homocysteine, we know that it is a basically intermediary amino acid, which basically formed by the conversion of methionine to the cysteine. So elevation in the plasma homocysteine is the major mechanism where the basically hyperhomocysteinemia is happening. And this is because there is some enzyme deficiency, from where the homocysteine is supposed to be converted into the other product, which is not being happening here. So I'll show you the picture here, the next slide. Just wait a minute, just we'll see the next slide, and then can you show me the next slide, please? Yes. So okay, so we can see here the homocysteine, and this homocysteine basically will form with the help of this vitamin, like vitamin B12. It will form the methionine, and this methionine will be there. And also this one will this homocysteine also will be converted into the other cysteine also as well. So that will be with the B6 vitamin. So when there will be enzyme deficiency in this pathway, so homocysteine will be accumulated in the body, and which will cause all these problems. Can you back to the other slide? Yeah. No, next. Before slide before. No, back. Go back.
Okay, sir, just a minute.
You are going forward. Yeah, this slide. Okay, fine. Okay. So basically, this is homocystinuria is basically autosomal recessive disorder. So as I said, there will be one enzyme deficiency, cystathione beta synthetase, which will convert the homocysteine to cystathione that is deficient. Then the homocysteine will be high. And the same way, if the homocysteine is not converted into the methionine, so so again it will be also the homocysteine will be accumulated. So there is this two enzyme deficiency, finally accumulating the homocysteine in the body. And so in the type 1, basically the cystathione synthesis is responsible, and in the type 2, the methylene tetrahydrofolate reductase, that is the which form the methionine. So this is the methionine, and another is the cystathionine formation. This one is the The type 1 is cystathionine formation, and the type 2 is basically methionine formations that is not happening because of this enzyme deficiency, and finally is causing the hyperhomocystinemia, and which is the cause of this hyperhomocystinuria. So as we said, there is this in this two enzyme, there are this enzyme is vitamin the B6 is helping, and here also the B12 is as a cofactor, this methylene tetrahydrofluororeductase. So this vitamins also, whenever there will be deficiency, they will also have hyper homocysteine level, increased level of homocysteine, which will also cause the similar high level. So there are some drugs also which cause hyperhomocysteine, like metformin, methotrexate, nicotinic acid, and fibrates. These are also associated with hyperhomocysteine. So it just you need to know when what are the other causes of hyperhomocysteine level, like the deficiency, as I said, folate, vitamin B6 and B12, CKD, and also this some of the drugs. Next slide. Next slide. So moderately, as I said, what are the symptoms we will have? The major problem is if homocysteine is basically, we'll call endothelial damage, and it's very highly prone for thromboembolic diseases. So endothelial dysfunction all and highly prone for these thromboembolic phenomena, so which may cause the cardiovascular and the cerebrovascular stroke, cardiovascular, like the this ischemic attack, and also the thromboembolic the thrombus formations in other venous thrombosis and the arterial thrombosis. All this can also form. And the like other symptoms, like the patient have a neurological, like learning disabilities, and mental retardation and seizures, and ocular, some lens dislocation also happens here, and some so and sometimes sudden visual deterioration, that because of the thrombotic occlusions of these arteries, and some lens dislocation also may cause the visual deterioration. And there is, as I said, there is increased chance of venous thromboembolisms. So its thrombosis in the either in the form of stroke or in the form of myocardial infarction. These are the most common. This is very dangerous complication, which even cause death in this kind of patient. So diagnosis is basically made by cyanide nitroprusside test, which is also positive in cystinuria. So basically, so this test has to be done, and even the homocysteines level can also be checked. And this the main thing is that we the hyperhomocystinemia basically is we don't usually treat unless the if it is so much high level, causing the hyperhomocystinuria is also there. And in many cases, the vitamin supplementation works a lot. So the main issue is to reduce the intake of the methionine, and an increase intake of cysteine. And also we supplement vitamin B6 and B12 and also folate. As we see in the metabolism, these are the vitamins which help in the metabolism of the homocysteine to the cystathionine and also to the methionine. So this decrease the level of the homocysteine actually. Next slide. Next topic is primary hyperoxalurias. So this hyperoxaluria, basically the overproduction of oxalate in the body because of the inborn error of the metabolism of glyoxylate metabolism disorder. So this oxalate is basically very poorly soluble, so it will be deposited with the like calcium salt or anything in the various organs, mostly in the urine, cause calcium oxalate stone. and finally it mainly causes the kidney injuries and end stage kidney disease. So this glyoxylate metabolism pathway, the enzyme defect is basically autosomal recessive disorder. There are three types is there based on the basically there is a variant, genetic variant, how much the enzymes are there. Like there are different genes which encode the enzymes for this metabolic pathway. So based on that, there are three varieties are there. So normally this kind of informations may not be required for MRCP, but sometime it's they can given as an options as a true kind of thing. So it's sometimes it's very difficult. So just have an idea that different genes are there, what are the genes involved, and which encodes the particular gene in the metabolic pathway. And there, because of this error, the oxalate is being overproduction is happening, and finally this is the cause of deposition in the tissues and the symptoms. So the main issue is that in primary hyperoxaluria, there increased excretion when there is oxalate formation is more. This is coming in the urine, and oversaturation, as I said, like the cysteine, like also same here, the oversaturations and causing the calcium oxalate stone, and which is the oxalate is very sharp kind of stone is there. Many cases they comes with hematuria, and it damages the kidney very fast actually. So recurrent kidney stone and progressive nephrocalcinosis happen, and kidney function deteriorate as the stones the stone size increases and damages the kidney tissues. And how do you diagnose this case? Basically the same. If the kidney recurrent kidney stone happening on kidney stenosis, we do the urine test, and the way that we increase the urinary oxalate excretion is more, that's the way we diagnose it. And sometimes we do the molecular genetic testing. So mostly in the urine analysis we do the diagnosis of primary hyperoxalurias. Next. So management is basically, as I said, it is the type 1 is the most common and very severe form. So early diagnosis is the most important. Once the kidney already damaged, so it's very difficult. So no, the same slide please. Yes, yeah. So basically again the issue is to we have to keep the high fluid intake. That's the most for any kidney stone cases. And other cases, we can the solubility, we can like we can use the potassium citrate, we can alkaline the urine, so that the oxalate stone formation will be less. And the also some cases the pyridoxine trial also helps to reduce the urinary oxalate secretions. So pyridoxine can be used. And there are some trial there are some RNA therapy also available as a subcutaneous along with the vitamin pyridoxine. So the major issue, but the major management is the basically this fluid and this the potassium citrate, and also this vitamin. Next slide. Next slide please. Okay, thank you. So next topic is we'll discuss about the gout. So gout, we know that this is basically the crystal synovitis. So it's due to the deposition of the monosodium urate monohydrate in the joints, synovial tissue. So this is the inflammatory joint problems happening. And this is basically autosomal dominant inherited disorder, which is a juvenile one. And the major issues of the this is the primary and secondary gout is there because of the this hyper uric acid level due to different multiple other reasons. So when the uric acid will be chronically high, it will the this will be the risk of gout will be more. like if it is more than 7, the risk of gout and the deposition in the synovial tissue will be, chance will be more, and then the joint, this acute gouty arthritis will be, the chance will be more. And gout also, uric acid is also a parameter which have a risk factor for cardiovascular mortality and morbidity. Those who have cardiac, ischemic cardiac heart disease are more chances when the uric acid is more. Next. So there risk factor which is associated with hyperuricemia, gout, like age, sex, and the usually the higher age, and this and if we see the other risk factor, basically the more the patient is more obese, and the hypertension, and those have a metabolic syndrome, diabetes, and patient with kidney disease, and some of the more the protein intake, those and also the alcohol, those who take the alcohol, and some of the medications which can impair the excretion of the uric acid, which also causes the high uric acid. Can you go to the next slide, please? So hyperuricemia basically may be associated with high, the, as I said, the hyperlipidemia and hypertension, and commonly with the metabolic syndrome. And high uric acid itself is a very high risk for this. The cardiovascular risk factor is there who have a high uric acid, and the patient with hyperuricemia sometimes may be asymptomatic, and the gout attack sometime, due to the fluctuation level of the uric acid, can happen even with the normal level of uric acid. So this we need to know that even with the normal uric acid level, the gout attack may happen. And etiology of gout, basically as I said, the hyperuricemia, this is because either endogenous production is high, that is the normally in 10% cases the major reason is when the uric acid is not being excreted through the urine properly, and finally the uric acid level will be more high due to under excretion. So that is the major cases where the reason of the hyperuricemia. Next slide, please. So in this slide, we can see that what are the causes of hyper production of these. Basically, is hyperuricemia causes. There are inherited enzyme defect, which is the hypoxanthine guanine phosphoribosyl transferase deficiency, HGPRT. These enzymes basically is the genetic inherited cause. We also call Les-Nihan syndrome. Les-Nihan syndrome. This is also sometimes comes as a question. So this is the genetic cause mostly, but these are very rare causes. There are some other enzymes also, but this is the most common enzyme problems related to hyperuricemia. And there are other where the more cell destruction or the cell turnover is happening more. In those cases also uric acid will be high, like any myeloproliferative disorder, any lymphoproliferative disorder, even hemolytic disorder where the cell lysis is happening, in psoriasis, and also in some of the drugs, basically the cytotoxic drugs, those the basically cell lysis is happening. And so basically this is more of purine, and just from the purine metabolites the urea is overproduction is uric acid is overproduction is there. So even the dietary more intake of purine related uh, diet, if it's more intake in those cases, and those who are taking alcohol are risk factor of high uric acid level. Next. So basic the causes basically, I as I said, one more important reason is the decreased uric acid clearance. Uh, that is either from some clinical disease like the chronic kidney disease, or any nephropathy is there, any diabetes and lactic acidosis, and those cases, even like the patient with eclampsia, all these cases the decreased uric acid clearance is there. In those cases, that you usually find high urea level, and also some drugs associated with decreased uric acid clearance, like ethambutol, pyrazinamide, and low dose, like low dose aspirin, and sometimes some diuretic, thiazide diuretics mainly. So this is very important in these cases. Sometimes these drugs come as a questions. Many times we have seen some of the drugs which is involved with the high uric acid level. So drug affecting the uric acid level and causing the gouty attack. So thiazide diuretic is very important, and this ATT drugs, ethambutol and pyrazinamide, and also these cyclosporine and also involved with the high uric acid level. Next. So in gout we have a one clinical basically probability score is there. So we can to diagnose this with the like high probability of gout to the minimal low probability. So we can score with the if the patient is a male sex, the higher point 2 points is there, and patient with previously reported the arthritis, or there is 2 points is there, and other symptom like joint redness and onset within 1 day, and the if the patient has a first metatarsophalangeal joint, that is a classical joint where the gout attacks is mostly happens. So that is 2.5 points even. And another thing is serum urate level more than 5.8, that's the 3.5 points. So these are the points which, if it is more than 8, it is high probability, and between 4 to 8 it's intermediate, and less than 4 is low probability. Next. Okay, so this is very important slide. So the gout and the pseudo gout. So we know now we don't call it a pseudo gout. We call it a calcium pyrophosphate crystal arthritis. So it's basically CPPPD disease we call. So this is a crystal deposition happening. In both are the crystal deposition happening, but here is the monosodium urate, and other is the calcium pyrophosphate dehydrate crystal deposition here. And so crystal here in the gout is negatively bifringent, and and in CPBD disease basically.
Please mute your mic.
Hello,
Yes, sir, continue.
please continue, sir.
Yes, please. Okay, now. Okay, so basically this CPP calcium pyrophosphate dehydrate deposition is happening. So this is positively bifringent, and this is rhomboidal. This is very important. So this questions, this many times this question came in the Mrcp as. So, which are the joint basically in calcium pyrophosphate cases? This is basically the larger joint involved, and the gout initially the classically first MTP joint, that's metatarsopharyngeal joints, is a classically involved. So in other joints also involved eventually, and the risk factor is totally different for both of them. For gout, we already seen that the metabolic, those who are metabolic syndrome, obesity, hypertension, hyperlipidemia, alcohol, taking alcohol, and those have the other risk factor, those who have a gout. But in these cases, CPPD basically happened with the calcium, like hyperparathyroidism, and all, even with the hemochromatosis, and some old age with osteoarthritis, those cases can happen. Treatment essentially almost similar in the acute cases. Chronic cases, in the gout, we usually we give the urate lowering agent, and also colchicines. In CPVD disease, we give the painkiller and colchicine as well, and sometimes the disease modifying like hydroxychloroquine also given. Next slide, please. Next slide. Okay, so Lesch-Nyhan syndrome, as I already told, that this is the enzyme here is the inborn error. Inborn this enzyme deficiency. This is hypoxanthine guanine phosphoribosyl transferase enzyme deficiency, which is in the purine metabolism. So finally, this cause also cause the uric acid increased production, yeah, and hyperuricemia. This is basically in mostly because this is X-linked, so it will be X-linked. So it will be mostly affected in the it's only seen in the boys, and gout. It will, because of the uric acid high, the same gout manifestation, and the kidney will be involved here because of this the uric acid stone, and obstructive uropathy will happen. Mostly the treatment is to allopurinol will have to be given, and long term basis, and there will be some neurobehavioral issue also, and sometimes self mutilation, like tongue biting, finger biting, lips biting, all this also happen here, in addition to the neurological problem like learning difficulty, and the movement disorder like hyperkinesia, dystonia, all this kind of happens in Lesch-Nyhan syndrome. So very young, mostly in the boys, and because it is X-linked, and this gout like pictures, and features of neurological disturbances and self mutilation is the key point to identify this disorder. Next. So now we will discuss the copper metabolism problems. So copper depositions in the body, excessive copper deposition in the body, that is Wilson disease. So Wilson disease, also called hepatolenticular degeneration. Sometimes they will not give Wilson, they will give hepatolenticular degeneration as the option. So we need to know that this also called hepatolenticular degeneration. So it's a basically genetic disorder of the copper metabolism. So what happened here? There is an impaired function of intracellular copper transporter, ATP7B. So there is a copper transporter in the hepatocyte, or in other cell also, some of the other cell, mostly in the hepatocyte cell. Inside the cell there is a copper transporter called ATP7B transporter protein. So that basically help in the copper to excretion in the biliary pathway or in the plasma. So this, but when there will be this ATP7B will not be there. So this, from the liver tissue or in the other tissue, once the intracellular copper will not be able to go in the plasma or in the biliary tree, excretion is not possible. So when the excretion is not possible, it will be deposited mostly in the liver and also some of the tissue like brain and cornea. So that's the reason, and that will cause, finally the copper excessive deposition will cause the problem of liver dysfunction, and the brain also, when it deposited, it will have some the brain, the cellular degeneration, and also it deposit in the cornea itself as well. So major abnormality happens in the liver, which in terms of like maybe just asymptomatic patient will be some changes in the liver biochemistry, or like elevated enzymes, or simple hepatitis to the extent of cirrhosis and liver failure. So any spectrum of disease can happen, from just biochemical abnormality to the liver failure. So Wilson disease is when we suspect when there is an unexplained liver problem, like elevated enzymes, low alkaline, but alkaline phosphorus is normal, and hepatomegaly is there with a patient having some psychiatric and neurologic disturbances also. And when there is a family history, then it's a very high likely the patient to have some inherited problems. So Wilson disease is highly suspected in those cases. So in patient with suspected Wilson disease, the initial evaluation is basically we do the complete blood counts, serum ceruloplasmin, copper level, ocular slit lamp examination, and 24-hour urinary copper excretion. These all are very important. So each abnormality will be there. So based on that, we will the diagnosis of Wilson disease is confirmed. Next slide, please. So there is a scoring system. It's one German physician has that Leipzig, that scoring system for the Wilson disease diagnostic scoring system is there. So basically, they score based on the KF ring, neurologic symptoms, ceruloplasmin level, and also patient having non Combs negative non hemolytic anemia. So hemolytic anemia here is non-immune. Non-immune will be Combs negative. If it is immune, then Combs positive will come. So in this case, it will be non-immune hemolytic anemia. And also the liver, the copper deposition in the liver, and urinary copper concentration, and also the mutation analysis in the chromosome. So based on that, they have a scoring system. If the score is 4 or more, the diagnosis is established. If the 3, then diagnosis possible, then they will need more testing, and 2 or less is diagnosis very unlikely. So this scoring system also, it's not you need to know basically. Next system, next slide. So in the diagnostic testing, we do slit lamp examination. We know slit lamp, basically we do the copper depositions in the brownish golden ring shadows, which is basically in the descemet membrane of the cornea. So this color is golden brownish. So with the slit lamp, we can test that. And 24-hour urinary excretion is important. If it is greater than 40, so it's suggestive of Wilson disease. So we need to work up further for the to screen for Wilson disease to confirm the Wilson. And serum ceruloplasmin, when it is low, is all very highly sensitive. So we need to work up further for to confirm the Wilson disease. Next. Next, please. Okay. So serum copper concentration is usually typically will be serum copper. Initially, it will be low actually, but finally it will be more. And liver biopsy, the in the cell liver hepatocyte itself, the concentration will be more than the 250 microgram per kg dry weight. So when we do the liver biopsy, we just see the copper concentration, how much it is there per gram of liver weight, dry weight. So if it is more than 250 mics, this is very highly suggestive of this Wilson disease. And we can do the genetic testing also. So the ATP7B allele, when it is both biallele is involved, this confirm the diagnosis. And also we can do the brain imaging for the involvement of the copper deposition in the brain, like especially in the basal ganglia and brain stem, and also in other area of white matter, which cause the neuropsychiatric symptoms. Next. So Wilson disease basically, if a symptomatic patient, means when the patient comes with the liver dysfunction with a KF ring, and have some neuropsychiatric symptoms as well. In those cases, basically we initially do the serum ceruloplasmin, and the other test we do 24-hour urinary copper excretion. Along with the 24-hour urinary copper excretion, we also do 24-hour urinary creatinine, because that creatinine will help us to whether we have collected the adequate sample of 24-hour urinary excretion or not. So 24-hour urinary creatinine also collected along with that. Now, if the ceruloplasmin is low, then if the urinary concentration also very high, more than 40, so it's confirmed the diagnosis of Wilson. But if ceruloplasmin is low but urinary concentration is not greater than 40, in those cases we have to go for the liver biopsy, and if needed, genetic testing. But normally we don't go for genetic testing initially. Either it's only done mostly for the family member, and other screening for the others, screening of the family member in those cases. Not usually liver biopsy and in this urinary concentration and the ceruloplasmin is enough for the diagnosis. So next is, if the ceruloplasmin is not very low, but the urinary concentration is very high, like greater than 100 mics per 24 hours, then also it is confirmed the diagnosis. But it is urinary concentration intermediate level. In those cases, we have to go for the liver biopsy. Liver biopsy, when the dry weight is more than 250 then per gram, then also it confirm. In other cases we have to go for either genetic testing. Mostly we have to go for the genetic testing. So main crux of therapy is main diagnostic points is that first we have to suspicion, then based on the ceruloplasmin, urinary copper concentration, and how much high level is there, and also in the liver biopsy how much dry weight is there. Based on that, the diagnosis is being confirmed. Confirmation is done. If there is doubt, finally the genetic testing has to be done. Next. So basically, the treatment here is Wilson disease is avoiding food which contain copper, because copper is deposition in the tissue. So we need to avoid the copper containing food. So we take basically copper containing whatever food is there. So we need to restrict those disease. And other thing is, because if the liver problem is happening, and patient will be high risk for hepatitis. So the hepatitis, all the vaccines and other vaccine has to be taken. And also we have to refrain from alcohol, because alcohol already will damage the liver. The liver is the major organ which is damaged in the Wilson disease. The goal of therapy is basically the copper chelation, and to remove the copper from the body as much as possible, and so that, and the intake has to be restricted so that the tissue don't tissue deposition decreases, and the improving the liver function happen. So the chelating agents most commonly used is the D-penicillamine, and the primary initial therapy. And if in other cases we can use the trientine and the oral zinc also. So in if the patient is asymptomatic and there is no organ damage, in those cases basically we even then we use that for those cases also we use the drug therapy. And because the drug therapy will be basically prevent the additional copper to be deposition, and finally it will prevent the disease. So as for prevention also, we can, if it is patient is asymptomatic but high Wilson disease confirmed, so we need to give some therapy to deposition, to decrease the copper deposition in the tissues. Maintenance therapy, basically we will basically based on the symptom improvement and the liver enzymes and the 24-hour urinary copper excretion. These things we have to follow. So copper excretion, liver enzymes, and symptom, this has to be monitored. And when the patient is on already D-penicillamine and trientine, and also on zinc, so therapy has to be monitored. And in these cases obviously the patient will require the maintenance lifelong. So uh, so because we cannot discontinue, otherwise the patient may progress to the liver failure kind of things. So this is so main thing is that the maintenance of therapy, and the existing the regimes, whatever we choose the medication based on the how much the toxicity profile of the drug, how much the patient is tolerating those drugs. Based on that, we can either choose the D-penicillamine on trientine, and also the zinc, based on the how much tolerance and patient preference is there. So next slide please. So we already discussed the management part actually. So basically, the general measure is vaccination, abstain from the alcohol, avoid the high content of copper, and obviously hepatologist has to be follow up a long term basis, and we have to choose the chelating therapy, either D-penicillin and trientine. And initial all the baseline investigation has to be done. And then initially in the weekly, and then monthly, and then every 3 monthly, we have to target the urinary copper excretions, and also the liver enzymes. Every 3 months we have to monitor. So when the patient is on therapy, so this is the most thing. And based on the side effect and tolerance, we have to choose the drug accordingly. And lifelong therapy is needed. That is the most important thing, the lifelong therapy. Next. So next is the iron accumulations. I mean iron overdose disease. Here I'll discuss about the hereditary hemochromatosis. So this is also a genetic problem where the homozygosity in the C282Y variant of HFE gene is happening, which is in the chromosome 6, which basically result in increased iron absorptions and deposition in the iron in the body. And uh, and basically this iron overload is the making main issue is that when the iron is overloaded in the body, it deposition in the several tissues, and which cause all the symptoms. And we have to suspicion based on the sign and symptoms of the iron overload when the ferritin is very high, and also there is a positive family history in similar cases of patients. And we have the iron profile is like signs of looking iron overload like ferritin high, and the transferrin saturation is greater than 45, but we don't have any other explanation for this. So in those cases we have to suspect this hereditary hemochromatosis. And the main issue, the main organ which is involved here is the iron will be deposited in the liver, which is caused unexplained liver disease will happen. And also the patient will be more fatigued, the patient will be heart failure, it deposits in the heart as well, and some kind of arthropathy. And also the patient will have symptoms of like skin deposition, also in the testicular deposition with a decreased lipido, decreased testosterone also. So all this can happen. And when the patient will have the high serum ferritin, high the transferrin saturations will be there. And patient in deposition sometime in the pancreatic tissue also cause the diabetes mellitus like pictures, which in a younger age people we will have a type 2 like pictures. And if we should do the iron study, and eh, and also the sign symptom based on the iron study and the sign symptoms, and also the uh, this mm, this the mutation in the gene involved also will be has to, as a part of the diagnostic methods. So basically, so when the individuals we don't go for here also same, we don't go for the genetic testing as a part of initial evaluation is mainly the iron overloads, and and some the clinical pictures which just basically point towards this disease. So, and this disease also need the phlebotomy, which depends on the deposition of the iron deposition and the ferritin level. When the typically the ferritin level is very high, like five more than 500, in those cases it's recommended for the phlebotomy. And we also do the other kind of screening for this patient, like if the patient is deposition of the iron is happening in the liver, we do for screen for the liver cancer as well. Same we do for the even in case of Wilson disease, any deposition disorder, we should rule out the any possibility of cancer in the affected organ. So the diagnosis usually we exclude when those patients who are not in iron overload or not homozygous for this particular HFE C2280Y gene. So though if this is not there, so diagnosis is fully excluded in those cases. So if the some of the iron overload signs are there, in those cases we have to find out the other causes of iron overload. We'll check what could be the other causes will later. Okay, so the main issue for individual who is iron overloaded but lack the homozygosity of this individual, like this gene, and uh, the we have to do the basically additional testing and serial monitoring for those patients. Can you go to the next slide, please? Okay, so based on the iron overload, we will see that what are the symptoms we and sign and symptoms we will get. So the patient will be mostly liver involvement and the cardiac involvement, and patient will have anemic. So the patient will be lethargic and fatigue. This is the most common symptoms they will come. And there will be hepatic enzymes involved, which is the elevated liver enzymes, and hepatomegaly and joint involvement, and also thyroid dysfunction can also happen. And impotence, as we said, it's deposition in the basically this testis, which also patient may have a decreased libido. And cardiac symptoms, signs of heart failure will be there, and the cardiac function, the ejection fraction, the pumping function of the cardiac will be also affected. And sometime so and other cases, patient will may have hyperglycemia due to diabetes like symptoms, due to the involvement in the pancreas itself, also deposition in the pancreas it's also. Next slide. So when we suspect a case of like hereditary hemochromatosis, basically patient will have signs of iron overload in the iron study, and also some family history. This is the initial suspicion. So we will get what will be the sign of iron overload. The ferritin will be greater than, usually in the female it is greater, and in the male greater than 300. So and the saturation, the transferrin saturation will be greater than 45%, irrespective of the age group. No, go to the next slide. Yeah. So if it is if the ferritin and the this transferrin saturation both are increased, and patient have HFP gene homozygous, then the diagnosis is confirmed. Okay, so this homozygous and the iron overload, so this diagnosis of hereditary hemochromatocytes is confirmed. And the in other cases it will be like possible. But in other discordant cases, like if the patient is ferritin is high but tsat is like normal or decrease, in those cases there will be possibility. So in the HH or the other causes of iron overload, we have to find out. Similar, in the tsat is high and ferritin is normal or decrease, in that case the possible diagnosis could be that HH genotype without iron overload, or the patient already treated with the HH. And if the ferritin and tsat not increased, in those cases basically so genetic testing not appropriate, only for the positive family history. Then in those cases we will go for the genetic testing. So next. So these are the other gene which is involved in the uh, hemochromatosis, and non HFP related hemochromatosis. So HFP is involved, and non HFP related other genes are involved. Just for the information, this is sometimes they comes with erratic questions, like some genes they will give the which are the gene involved in the this hemochromatosis. So HFE and along with the other non-HFE hemochromatosis genes, just for the informations. Sometimes it comes as a question. Next. So these are the other causes of iron overload. Apart from this hereditary hemochromatosis, we can see that when we increase the intake of iron in the dietary intake is more, or the hemine infusion is to treat for the acute intermittent porphyria, the treatment is hemine infusions. In those cases iron overload chance is there. And also we know that in the thalassemia major and intermediate cases, ineffective erythropoiesis, which also and transfusion related iron overload happens. And any other cases of anemia where basically the iron overload happen also happen. And some cases of chronic liver disease also, this chronic hepatitis, and those cases we see the iron profile with iron studies the elevated level. Next. So management of HH is basically we have to suspect the diagnosis, and then we have to diagnose it. So if it is homozygous variant, then and we have the evidence of the iron overload. The iron overload, I already said how much the ferritin should be in the male and female, and also the TSAT should be greater than 45%. In those cases, and we have to, the basically you have to see the spectrum of disease like liver, how much involved, and cardiac MRI to whether the tissue deposition of iron happen or not. That will basically guide us the therapy. So once if it is already diagnosed hereditary hemochromatosis with the HFE gene with iron overload, the candidate is for phlebotomy. So we have to start the phlebotomy, and we have to guide the therapy based on the iron studies and repeated monitoring of this tissue deposition, mostly in the liver, and the cardiac MRI are done, and sometimes the biopsy also. So those things will guide us the phlebotomy therapy of phlebotomy, how frequently we have to do that. And other cases, like if it is without iron overload, then just to monitor the iron indices. And in case there is the homozygous but non-homozygous, but the excess iron is there, in those cases basically also we have to tissue deposition is there or not, in the especially in the liver and the cardiac MRI and the biopsy MRI and the biopsy we have to do. And if it is the iron tissue deposition is there, in those cases we have to individualize, like the how much treatment we have to give, like iron chelation, this phlebotomy we have to do how frequently or not. But in other cases basically we have to just monitor the iron profile at frequent interval, so whether it is increasing or not. So the main issue is that we have to basically the based on the ferritin, we have to monitor the ferritin every monthly, and with the each phlebotomy, and the urgency and the frequency of the phlebotomy depend on the how severity the iron overload is there. So based on that we have to individualize the target ferritin and target tsat therapy. Based on that we have to how frequently phlebotomy is needed, and alternatively some iron chelation therapy, some other extra like exclusive therapy like erythrocytophoresis may be used in selected individuals, like these are the basic management. So mainstay of therapy is the basically phlebotomy. Okay, the next slide please. And also one important point, as I said, in iron and copper all deposition, you have to patient screen for whether the patient is developing any cancer. So they have so this will be if they do the liver biopsy, it will be automatically detected, and in other cases the tumor marker for the liver cancer also has to be monitored. So the result of last slide, yes, yeah. So we see that there is some complications of iron overload there. So if we do the phlebotomy, so in those cases most of the symptoms will be resolved, but many will not be resolved. Like if the patient already have damaged cirrhosis, and hepatic damage has already been damaged, so in those cases it will not come back, because that is a irreversible damage. It's very obvious that it will not come back. So this is important to know, that if already some diseases irreversible damage happen, it will not come back. And many other cases like cardiomyopathy, some resolution will happen. Hyperpigmentation, you will also resolution will happen. And obviously if it is just in the enzyme is raised, not much damage happens, that will also mark improvement and resolution will happen. And and one more thing important is that you need to know that that this the main issue is that, so monitoring the frequent monitoring of this kind of patients with this all parameters, especially the cardiac MRI and the liver MRI, and also this at times needed the biopsy while the patient is on therapy, is the main monitoring parameter, including the biochemical test. So okay, so I think this is end of this here. Basically, so we discuss Wilson hemochromatosis and also some amino acid metabolism disorder, along with some of the other cases as well. So So we can discuss basically, see all these metabolic disorder cases, the carbohydrate, lipid, and all these things I will discuss in the next class. This usually 4 to 5 question will come. There will be hardly, and sometime it will be less than that, maybe 2 to 3 question only. So but we need but these are actually, it's not very difficult. We need to know some of the information which will help us to answer those questions, and we can actually correctly answer and score full marks on those 3 4 questions. If you have any question, just you can ask. We
Aspirants,
will
if you have any question, you may ask.
If anybody have some questions, then please raise.
please raise the questions, no problem, we'll discuss, no issue.
Sir, I believe no aspirants have question as of now. But if any question arises, we'll be scheduling a
Yeah,
class.
next class we'll discuss in next class, no problem, no problem.
Thank you very much, doctor, for the session, and
Yeah, thank you.
hope you'll be all have been that's been a very outstanding session. Thank you very much to all the aspirants, and thank you very much, Sujay sir. Thank you.